Welcome to Pulse&Pressors, where critical care gets crystal clear. Today we're mastering Amiodorone, a broad-spectrum antiarrhythmic that can convert chaos to sinus rhythm without crushing cardiac output. Amiodorone is labeled Class 3 for its potassium channel blockade, but it behaves across 4 classes. It prolongs repolarization and the effective refractory period, slows sodium-mediated conduction, dampens calcium-dependent AV nodal transmission, and blunts adrenergic drive with non-competitive beta blockade. That multi-hit profile explains why it works in both ventricular and atrial myocardium, and why it remains effective when the ventricle is dilated, scarred, or weak. Let's be exact about indications. In cardiac arrest with shock-refractory VFib or pulseless VTAC, after defibrillation and epinephrine, Amiodorone delivers membrane stabilization and breaks reentry. In sustained monomorphic VTAC, it terminates the arrhythmia and reduces recurrence, which is critical in electrical storm. In the atria, it serves conversion and rate control for AFib or Flutter when patients have left ventricular dysfunction, structural heart disease, or intolerance to alternatives. And it's a go-to for post-operative AFib after cardiac surgery. It is not first line for Torsades de pointe. Magnesium and overdrive pacing led there. But Amiodorone may still appear later once magnesium and precipitating factors are addressed. Kinetically, route changes the story. IV Amiodorone acts in 15 to 30 minutes, perfect for emergencies. The early punch is redistribution, so the apparent effect fades if you stop the infusion. Oral Amiodorone requires loading over days to weeks to saturate tissues. Once the reservoir is full, its half-life stretches into months. That's why we bridge IV for immediate control, PO for endurance. On the monitors, the drug has a gentle hemodynamic signature. Heart rate falls, blood pressure may dip during a bolus, but contractility is comparatively preserved, a key advantage in low EF patients, where many antiarrhythmics worsen outcomes. If hypotension occurs during a bolus, think infusion rate and solvent, slow down, dilute, and support. Here's how we actually dose it. In cardiac arrest from VFib/pulseless VTAC, push 300 mg IV or IO, then 150 mg if the rhythm persists. For sustained VTAC or AFib with RVR in a monitored setting, load 150 mg over 10 minutes, then infuse 1 mg per minute for 6 hours and half a milligram per minute for 18 hours, totaling about 1 gram in 24 hours. Give additional 150 mg boluses for breakthrough VTAC or VFib. Transition to oral therapy with 800 to 1600 mg per day for 1 to 3 weeks, tapering to 200 to 400 mg daily for maintenance. Therapeutically, Amiodorone suppresses ventricular ectopy, terminates VTAC or VFib, and converts or controls AFib or Flutter, even in structural heart disease. That breadth is why it's so often the stabilizer when other agents falter. Be cautious of its risk profile, especially QTC prolongation. Although Torsades is less common with Amiodarone than with many other Class 3 drugs, the risk is real when QTC is greater than or equal to 500 milliseconds, when QTC rises more than 60 milliseconds from baseline, or when potassium and magnesium are low or other QT prolonging drugs stack. In practice, we keep potassium above 4.0 and magnesium plus above 2.0, avoid poly-QT drugs, and hold or taper if the QTC crosses those thresholds. Acutely, watch for bradycardia and AV block, and treat hypotension by slowing or pausing the infusion, diluting, and supporting blood pressure. Over the long term, watch for pulmonary toxicity, subacute interstitial pneumonitis that can progress to fibrosis, as well as thyroid dysfunction, hepatic injury, ocular deposits, neurologic symptoms, and photosensitivity. Baseline and periodic ECG, QTC, liver enzymes, TSH, and free T4, and for longer courses, chest imaging and pulmonary function tests with the diffusing capacity of the lung for carbon monoxide keep patients safe. Now to the cardiac surgery patient. Why is Amiodorone so popular post-CABG? Because it reduces post-operative AFib, shortens length of stay, and works in an inflamed, atrially irritable milieu without heavy negative inotropy. Typical prophylaxis looks like this. Start 4 to 600 milligrams orally per day for 2 to 5 days pre-op. Then continue 200 milligrams twice daily for 5 to 7 days post-op. Or begin early post-op with a 300 milligram IV load, then 4 to 600 milligrams orally per day for several days, before stepping down to 200 milligrams daily. Patients at high risk, older age, prior AFib, enlarged atria, valve surgery, gain the most. Each day post-op, check heart rate and QTC, maintain potassium and magnesium, and adjust for bradycardia or hypotension. Remember interactions. Warfarin and digoxin levels rise. Statins metabolized by CYP3A4 need caution. Reduce doses and monitor. Contraindications include severe sinus node disease or high-grade AV block without a pacer, severe hepatic disease, and iodine allergy. Black box warnings remind us of pulmonary toxicity, hepatotoxicity, and proarrhythmia, the very reasons we monitor relentlessly. 3 closing pearls. First, Amiodorone is multi-mechanism. It buys time by attacking arrhythmia from several angles. Second, QTC Discipline saves lives. Target potassium greater than 4, magnesium greater than 2. Avoid QT stacking, and act when QTC greater than or equal to 500 milliseconds or up by greater than 60 milliseconds. Third, plan the bridge. 4 to PO for continuity, then taper to the lowest effective maintenance dose. Used wisely, Amiodorone is one of the most reliable tools we have to turn lethal rhythms into sustainable circulation. This is Pulse&Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.